with Dr. Stella Milsom. My name is Lydia Hemingway. I am the CEO of Fertility New Zealand, and I'm delighted to be joining this evening with you all. Fertility New Zealand walks alongside all people facing fertility challenges. We do this through providing support, information, and advocacy services for people who need us. You can contact us through our helpline. We have an 0800 number and email, or through social media. You can connect with us. All of the information is on our website as well, fertilitynz.org.nz. We're also on social media through Facebook, LinkedIn, and Instagram. You can join Fertility New Zealand as a member. Membership is absolutely free, and by joining you have access to a few extra resources as well as supporting the valuable work that we do. Please visit our website, like I mentioned, fertilitynz.org.nz, for lots of information and resources. There's fertility fact sheets, previous webinar recordings, issues of Dandelion, our newsletter, and so much more. Tonight's webinar is brought to you. Oh, sorry, those were just some slides there with some information for you. Tonight's webinar is brought to you by our sponsor, Merck, who we're very appreciative of their support in allowing and helping us make this happen. Tonight's webinar is PCOS and Fertility. Polycystic Ovary Syndrome is a serious genetic, hormone, metabolic, and reproductive disorder affecting women. It occurs in around 5 to 8% of Caucasian, Māori, and Polynesian women, and is more common in women from India and the Middle East. I'm delighted to now introduce our guest presenter, Dr. Stella Milsom. Stella graduated from the University of Otago, followed by postgraduate training in Christchurch and Auckland, doctoral studies with Professor Peter Gluckman in the University of Auckland, post-fellowship training at the University of Utah, USA, and Middlesex Hospital and St. Bartholomew's Hospitals in London. She is currently the Senior Reproductive Endocrinologist in the Department of Reproductive Medicine at National Women's Hospital, leader of the Reproductive Endocrine Group at Fertility Associates in Auckland, and also a clinical senior lecturer in the Department of Obstetrics and Gynecology at the University of Auckland. Stella is on the boards of Osteoporosis New Zealand and Human Fertility UK. She is the past chair of endocrinology training in New Zealand for the Royal College of Physicians, is a member of the National Health Committee's formulating guidelines on hormone replacement therapy and fertility preservation, and she's an advisor to PHARMAC. Her clinical and research interests include lactation physiology, ovulatory disorders such as polycystic ovary syndrome, and hypothalamic amenorrhea, and modern menopause management. She is involved in numerous Australasian educational initiatives in reproductive endocrinology and has been the recipient of several awards for research and clinical leadership, including the Kay Iverson Award in 2021. Wow, she is certainly the right person for this webinar, and we are privileged to have her with us tonight. Thank you so much, Kay. Just before I hand over to you, Kay, for those of you listening out there and watching, if you have any questions, please pop them in the chat box or on Facebook Live, and we will get to them towards the end of the evening. Thank you so much for joining us, and we hope you enjoy the webinar. Now, over to you, Stella.
Thank you very much. And look, good evening to everyone from a fairly unpleasant evening in Auckland. It's probably not a bad night for a little spot of education. So look, my job tonight is to talk to you a little bit about PCOS, which in full is Polycystic Ovary Syndrome, how it might affect a girl or a female in general in terms of her health, and also particularly how it might affect one's fertility. And I am grateful to my colleague, just move the slides on, Dr. Maritza Farrant, who's on the left of this cartoon, just for helping me with slides, and also Kate from Fertility New Zealand. This is our group of endocrinologists, reproductive endocrinologists. That means we're hormone specialists. So we're a group within the wider group of fertility associates. And while we're sort of involved in fertility associates around the country and also within the DHB, now Health New Zealand, our group's based in Auckland. Now, what are we going to do tonight? Just so you've got an idea of what we might cover, I want to talk about what PCOS is, what might cause it, and I might say that's actually very hard to pin down. What sort of symptoms might suggest that a female might have PCOS, whether or not it runs in families, what it affects apart from fertility, because I think we've got to think of it as a very broad-based condition, but obviously for the audience tonight, what impact PCOS might have on someone's fertility, and what treatments that we use as fertility doctors, and also perhaps just some general advice about funding in New Zealand, about rules around public funding and availability of treatments, whether women should actually see a fertility doctor if they know they've got PCOS, and particularly the sort of things that a female can do herself to help the PCOS symptoms and her chance of getting pregnant. And I think that that's a very important issue which we will focus on a little bit later in this presentation. Now, just to begin with, what actually is polycystic ovary syndrome? And I think, first of all, the terminology is dreadful. It doesn't mean one's ovaries are full of cysts. Any woman can have a cyst in her ovary, and usually they're quite large and they can cause symptoms such as pain if they twist or burst. These are actually little follicles, so it would be better termed polyfollicular syndrome, but I can't be the only person in the world that changes the name. So the ovary, and as you can see in the middle of the slide, a normal ovary might just have 1 or 2 follicles. And if you look to the right of the slide, you can see a polycystic ovary has multiple little follicles. And these are basically eggs that are trying to develop and don't quite get there. So in medical terms, we call them atretic. So they're, if you like, poorly or underdeveloped follicles, and there's lots of those in a polycystic ovary compared with an ovary that's not polycystic. Now, the follicles themselves don't really matter. It tells us what to look for. They themselves don't cause pain or trouble, and I think that's important to understand. If you have polycystic ovary syndrome and you have pain in your tummy or abdominal area or your pelvis, that needs investigation like anyone else. Pain is not part of this syndrome. Now, the cardinal features, the core features, if you like, and remember that not all women will have all of these features, but the key ones are male hormone excess, and in medical terms, we call that androgen excess. Androgens are the terminology for male hormones. And that is associated with irregularity of periods, which in turn suggests that a woman isn't ovulating, and potentially these polyfollicular ovaries, if you do a pelvic scan, make up the features of polycystic ovary syndrome. And underpinning all of this, not just these symptoms, but is another hormonal condition, if you like, which is where there is insulin resistance. So for some reason, the polycystic ovary responds to insulin, and anything that you do, like gaining weight or becoming sedentary, that builds up insulin levels will in turn cause that polycystic ovary to make more male type hormones, and in turn cause more trouble with ovulation. So the insulin resistance part of the syndrome isn't a good thing, and anything one can do to reduce that is helpful in this syndrome. Now, remember what I said, not all women have all of these symptoms, so they might have 1 or 2 or 3, and just over the decades, symptoms might change, and the symptoms that bother a girl or woman might change over time too. Now, you've heard before, it's actually a very common condition. This is probably the most common condition that affects reproductive age women. So anything between, say, 7 and 15% of women, depending on how you define it, will actually of women will have this condition. I wish we knew what caused it, and so do my patients, but it seems like, just in general terms, there are some genetic features, and we know that if we diagnose PCOS and we look hard at the other women, the other female relations in a family, we will find half of them will have some features of PCOS. So there are definitely genetic causes, but it's not just one gene. It might be multiple genes that can have an influence on the way the ovary develops. And there's no doubt that interacts with lifestyle. And particularly, it interacts with gaining weight and becoming sedentary. They are not a good combination. Together, that can lead to the hormonal changes that I've talked about, the rise in insulin, the rise in the male-type hormones. Then, in turn, we get these symptoms that we have mentioned. Now, in the ovary itself, as I've mentioned, in a normal ovary, as you see on the left of the slide, you've probably only got 1 or 2 developing follicles at a time in a polycystic ovary, and we call that polycystic ovary morphology. So that alone isn't enough to determine the syndrome, but you'll have multiple little follicles. So cysts are a bad term, there's multiple follicles. Now, in terms of symptoms, I think probably the symptom that makes us think about polycystic ovary syndrome or PCOS is when the menstrual cycle is irregular. So what's normal? Normal periods should come anything between 3 and 5 weekly, and they should be regular within 1, certainly 2 years of having your first menstrual period. And the first menstrual period in a teenager should have occurred at least by the age of 50. So I think we make a lot of mistakes in New Zealand. We put down being late to start periods or the menstrual cycle being irregular. We put it down to being a teenager, to stress, or we say it runs in the family. Just be careful not to be too quick to rush to that. Think about some of the potential underlying causes, and certainly PCOS might be one of them. Now, if the periods are irregular and they persist in being irregular after we've started our periods, we've gone through puberty, and particularly if there's acne or there's excessive, more male-type hair growth, or both of them, and particularly if acne is quite hard to treat or it goes on to adulthood, these are certainly pointers and red flags that might make one think of a diagnosis of PCOS. Occasionally, another symptom of the male hormone excess is actually female pattern hair loss, where hair loss on the scalp, rather like a man, can start. So those are the symptoms. As I said, one might not have all of those symptoms, but a constellation of several of those symptoms would make certainly me think that a female might have PCOS. Now, in terms of diagnosis, we use something that's called the Rotterdam Consensus. We've just had, if everyone's keen to read, we've got very good guidelines published in 2018 by my colleague in Australia, Professor Helena Teed. And it having, if you like, been very controversial around the world as to how you might diagnose PCOS. And of course, particularly now that we come out of COVID times, people travel. So I've always had to say to my patients, look, I'm going to diagnose this condition in New Zealand or in Australasia, but if you go to the States, for instance, they might have a different focus. So I think it's a really good thing that we've internationally agreed on using the Rotterdam Consensus. And that means looking at the 3 features, the 3 cardinal features I've mentioned: the irregular periods, the lack of regular ovulation, the male hormone excess, either in the blood or symptoms of it, and the polycystic ovaries. And if you've got 2 out of the 3, and as an endocrinologist, we do 1 or 2 other tests to just rule out other things, but 2 out of 3 of those criteria would lead to a diagnosis of polycystic ovary syndrome. So that has become far more universally accepted. I've shown you a picture of a polycystic ovary on a pelvic ultrasound just at the top of that slide for those that are interested. And I think that does make it simpler, particularly in women who've been diagnosed in another country and come to New Zealand, or similarly someone who moves overseas. Now, we've talked a little bit about hereditary genetic. There definitely are some genetic factors, but there's not just one single gene that means you have it, you've got PCOS, you don't have it, you don't. And so it would be a lot simpler if the diagnosis was as simple as that. As I've said, there are probably multiple genes that have an influence, and it's very clear that the environment that a girl or a woman lives in also influences the development of PCOS, and particularly by that I mean gaining weight. Now, I want to just stress that PCOS is not just a gynecological condition or a condition that might affect fertility, or if you like, a cosmetic condition that might affect the way your skin reacts or whether or not you're more hairy than other women. There's a lot more to PCOS than that, and I think that having said that, it means that it's really important that if you like, a generalist has an overview of a girl or a woman with PCOS. Now, one of the things you need to be aware of is that there are metabolic risks with PCOS. There is a significant increased risk of things like diabetes, high blood pressure, high cholesterol, even fatty liver, even sleep disturbances. So, of course, all of those can in turn lead to a risk of cardiovascular disease. So I think that's really important when you're thinking about the diagnosis and you're thinking about lifestyle and what to monitor. Another thing that's really important, none of us like having periods. And so it's not uncommon for patients to present to me and tell me that they only have 1 or 2 periods a year, and it's been like that for ages, and they're really quite pleased that that's the case. So socially, that might be pleasant and easier, but from the medical point of view, because those little follicles release lots of the female hormone estrogen, that can increase the risk of precancerous, even cancerous changes in the lining of the womb. So the lining of the womb is called the endometrium. So the risk to the endometrium, if periods aren't coming in a reasonably normal fashion, it needs investigation and management. And I can't stress that enough. The other area that we are starting to become increasingly aware of is that polycystic ovary syndrome has mental health issues associated with it. And that might be an increased risk of depression and anxiety, but also things like eating disorders and even body dysmorphism. So, this is a condition that affects lots of different systems and organs in the body, and we need to consider it, as I say, not just as a gynecological condition or a fertility condition, but as a more general condition that needs management. Now, this is just showing, if you like, the overlap of the reproductive, the metabolic, and the psychological features. It's a condition that needs to be managed, I guess, in a very holistic way. Now, in terms of treatment, I guess the first thing to say is that by the time it's diagnosed, someone's actually had PCOS since before puberty. We just haven't had any indications that they've got PCOS until someone starts or doesn't start their menstrual cycle. So we manage it. There's not a cure per se. There's not any magic wand that we can wave or a particular medication that we can give that says, okay, it goes away again. So it's managed, not cured. And the way we manage it might differ depending on what a woman wants. So there'll be issues that affect her goals, which might be, for instance, to improve her hair growth, to improve the acne. It might be that the periods are driving her crazy because she never knows when her period's coming. Might be fertility that's desired. But from the medical point of view, when you're seeing a doctor, your doctor also has to think about the important things like the metabolic risk, for instance, the diabetes risk, the cancer risk. So it's really important to have an open conversation where both if you like, the medical goals are achieved, but also a patient's goals. And of course, all of this might change depending on stage in life. I'm very privileged to look after really a very big cohort of girls and women with PCOS. And they may come to me as a teenager for diagnosis, and then they might go overseas, and then they come back because they want something else treated, like they're sick of the acne that's persisted perhaps into their 20s. They might disappear again, then they come back when it's time for a baby. And so just remembering different goals at different times. Now, let's just focus a little bit more on fertility, because I'm very aware that the audience will be very interested in fertility and how PCOS might affect fertility. So I think the first thing to say is that it won't necessarily affect your fertility. You can have a diagnosis of PCOS with the changes in the ovary, and you might have the androgen excess symptoms and have quite regular and ovulatory cycles. So it may not affect fertility. And in fact, overall, the percentage of women with PCOS who have subfertility as compared with the general population is probably not too different. But there is no doubt there's probably a small group of PCOS women. Sometimes it's the women who've got the very high androgen levels, who perhaps will have more difficulty than others in achieving ovulation, and where they're going to need a helping hand. So it's around ovulation, and the clues, if one is not ovulating, is that your menstrual cycle is not falling in this 3 to 5 weekly menstrual cycle. It's either shorter or longer than that, or there might be bleeding even all the time. There may be no bleeding at all. All of those are warning signs that ovulation is not occurring on a regular basis. And I just want to emphasize, and I'm going to refer to this again, that in this setting, that gaining weight or becoming more sedentary, which is really common for all of us as we sort of leave school, we drop out of sport, we study, we have sedentary jobs like myself, we're looking at a computer. All of those changes are negative in terms of the chances of ovulation and success in terms of fertility. So really important to think about that from an early stage. Important to understand that gaining weight reduces chance of pregnancy and increases chance of miscarriage. Now, I also just want to emphasize that in the human race, as we get older, the number of eggs that we've got that could go through to having an ovulation gets less. So we've got the most number of eggs actually when we're in the womb. The numbers are less by the time we're born. It's about 1 million. And you can see in that slide that the number of eggs, it's on the left axis, on the vertical axis, that's the number of follicles, are reducing all of the time. Sorry, I've just had a notice. Is there any problem with the Facebook broadcast? Kate or Lydia, is there any problem with the Facebook?
We'll look into that in the background, Stella. You just
okay. No, not to worry. Okay, all fine. Just a notice came up on my screen. Apologies. So back to the number of eggs. So you can see it's downhill. We're programmed to have less, and particularly if you're looking, into this sort of mid-30 area, there's a significant decline in fertility. So I think we have to be aware that for the female, very much so, age has an effect on fertility, let alone any other conditions like also having PCOS. And it might influence decision-making about timing if things were practical. So what fertility treatments have we got available? So in terms of PCOS, if someone's ovulating nicely, then they just proceed like anyone else. But if they're not ovulating at all, or they're ovulating very infrequently, then it means over a year, the chance, of being able to become pregnant is a lot less. Now, again, if you're trying to become pregnant at 20 or 22, it may not matter if you only have 4 or 6 ovulations in a year, because you've still got a very good number of eggs. But if you're 37 and you're only having 2, 4, 6 ovulations in a year, it matters more because the baseline number of eggs are less. So thinking about age as it interacts with what else is going on is important. So if the menstrual cycle is irregular, and we've got various ways of testing whether someone's ovulating, we will do something that's called ovulation induction if a patient's goal is to become pregnant. And we might look at lifestyle changes, and I'm going to come back to that. We might use a tablet called metformin, which is actually a diabetes tablet, but can often help in this setting. We might use letrozole or clomiphene. These are both tablet treatments taken for about 5 days a month. And if these don't work, then we might get into more complicated treatments, FSH treatment, which is a daily injection. We might even do a procedure on the ovary, which involves a small operation, and it sounds slightly fierce, but drilling very tiny holes into the ovary, which can sometimes kickstart ovulation. And if we really have our back against the wall, and certainly as a reproductive endocrinologist, this would be relatively rare. We've got IVF or in vitro fertilization as a backup. Now, this is just really to show you how ovulation induction works. All of these medications or injections are trying to trick the pituitary gland into producing more of a hormone called follicle stimulating hormone, which in turn, as you might imagine, stimulates the ovary to make more follicles and give more of a chance of an egg being released. Now, just thinking through how we might approach this in a young woman who presents to us wanting to be pregnant and who has PCOS and who is anovulatory. So she knows her menstrual cycles are really quite irregular. So first of all, there'll be a little step back, and this can be frustrating for patients who want to get right stuck into things, but it is important that we know about general health because that may in turn affect what happens in a pregnancy. So there will be screening for metabolic risk factors, weight, blood pressure, cholesterol, diabetes, liver tests. We'll probably run some thyroid function tests. So don't be too frustrated if I'm doing something like that. It is important in terms of the general scheme of things. We also need to be sure, just because a woman's got a diagnosis of PCOS, could there be anything else that's affecting her ovulation? Could her PCOS, in fact, be a bit of a red herring? Could there be something like thyroid disorder? Could there be adrenal disorder? Could there be a pituitary disorder? Or could there be a raised level of milk hormone? So some of those tests will also be done generally on the initial blood tests. And the first steps will be thinking about reducing insulin levels, preferably with lifestyle intervention. And it may be that we use a medication called metformin. And remember, I said that also lowers insulin levels, just like losing weight, just like exercising. And it's a tablet actually used for diabetes, but it's often used in the PCOS setting as well. And the advantage of metformin is that it's a normal prescription. It doesn't have to be done in the setting of a fertility clinic. So it doesn't involve any special costs or any special surveillance or screening, apart from a little bit of a look at liver and kidney function. So that would generally be the starting point. Now, not all women will achieve lifestyle modification, or it may be that it's inappropriate. Someone's presenting close towards the end of the reproductive life, and there's always a trade-off between the number of eggs and reproductive time that a woman's got left, the size of the family that she wants, and the treatment options that one's offering. So if the lifestyle modification is unsuccessful or it's inappropriate, we would move on to monitored letrozole. So in the past, it would have been clomiphene, and we know that letrozole is probably tolerated better and seems to have a slightly more efficacious effect. And as mentioned, it's a tablet taken for 5 days, and most often it's done in the setting of a fertility clinic. But it would be possible for it to be done by an endocrinologist or a gynecologist who is experienced in using it. Now, if letrozole not successful and someone still isn't ovulating, then we get into these more complicated treatments such as the drilling of the ovary or the FSH injections. And as mentioned, we have IVF as a backup. And IVF might come into the picture a little bit sooner if there were any other fertility issues. For instance, if we knew that there was a male factor, that the sperm wasn't all that good, if we knew there might be problems with one of the fallopian tubes, if we knew a woman had a condition called endometriosis. So all of that does come into the decision making, and of course a woman's preference to what she would like. Now, I just want to take you back to the lifestyle changes, because I think as a reproductive endocrinologist, we know not only does this work in many cases, but it is something that a woman can do herself. It doesn't involve us prescribing or doing relatively unpleasant procedures. It doesn't involve cost. It is something that can be done in the community. And in fact, as soon as the diagnosis of PCOS is made, I think concentration on a good lifestyle, a PCOS-friendly lifestyle, is really important. And in fact, for many of my patients, if we move them back to the sort of healthy lifestyle they had when they were younger, lose a little bit of weight, get exercising, and my patients, if any of them are listening, will know that their very firm endocrinologist wants them to be fit enough to literally run a half marathon from my office. So we know that that develops muscle, we know that that reduces insulin, and we know that that takes off the brake on ovulation and allows many women, in fact, basically PCOS women, unless they're particularly lean, will benefit from this approach. The problem is it's not always easy to accomplish. But I think understanding how important it is for the hormone changes makes a big difference. And I do want to emphasize that any weight gain in PCOS worsens PCOS symptoms. So it's quite hard on PCOS women. Even small amounts of weight gain, even becoming slightly sedentary, makes a big difference, whereas a woman who doesn't have PCOS will have to be really put on more weight and become more sedentary before she gets those same negative effects. And in my view, a multidisciplinary approach, an experienced nutritionist, a psychologist can be extremely helpful. It's not always easy. It sounds easy to say these things. They are really important, but everybody needs support. And in some situations, we even consider weight loss surgery before the fertility journey is embarked on. Now, as I've mentioned, does it matter what type of exercise? No, it doesn't. I think a combination of weight-bearing exercise and cardiovascular exercise, whatever someone prefers and enjoys and can accomplish, is going to be helpful. Don't forget things like smoking, recreational drugs and alcohol. None of those are good for getting pregnant. So it's a whole picture. And also don't forget that the men need to make these changes too. It's just as important for men, and fertility is very much part of a couple issue. Now, we've talked about how to do these insulin sensitizing approaches. Metformin, weight loss and exercise all reduce insulin levels. And it might be that a woman just wants to make lifestyle changes. She might want to make lifestyle changes and also undertake metformin, which could be prescribed in primary care. It doesn't need a specialist to prescribe metformin. The other quite nice thing about metformin is, and it's probably because it can cause some gut side effects, it can even help with the weight loss journey. Now, we've talked, I think, about letrozole and clomiphene, that we tend to use letrozole now. We think there's a higher pregnancy rate, fewer side effects, and particularly less chance of multiple pregnancies, which was an issue with clomiphene, generally done in the setting of a monitored cycle within a fertility clinic. Now, FSH are the injections. And probably in New Zealand, because of the way the fundings is applied, we're probably doing less FSH injections and possibly going to IVF. It's certainly in the hands of the reproductive gynecologist for a variety of reasons. Some of those are because it's a little bit easier to control the cycle. It may be quicker to pregnancy, and there is the option in IVF that one could get a number of embryos created, and therefore it's a little bit easier to look at family completion. But there's also a downside to that, and not the least is cost and the potential for overstimulation and other areas. So it's a weighing up, and it probably depends on where one's being managed. So if you were being managed for PCOS in the UK, for instance, you would have FSH injections rather than IVF. In Australasia, it tends to be a quicker pathway, I think, to IVF. And ovarian drilling has possibly gone a little bit out of vogue, and it will depend where you're listening from in New Zealand and your gynecologist's preference. This is when you just make some tiny little burns to the ovary. I know it sounds fairly ferocious, but it seems like it resets the ovary. And perhaps one of the advantages about doing this is you can also examine the fallopian tubes to make sure that they're patent and an air can travel through at the same time. So it might be something, if we're going to do a laparoscopy and a look-see, perhaps you might be wondering about endometriosis, you want to know about tubal patency, and you know that there's PCOS, you might diathermy the ovaries at the same time. And there is the potential, if it's done at the right time when someone's desiring pregnancy, that you might even get several pregnancies. It's not something that we do well ahead of anyone wanting to get pregnant. It's done at the time that people are considering it. But again, there are some potential downsides that just need to be discussed when you're making decisions around these options. And I think in terms of IVF, and it probably depends whether your fertility doctor is a reproductive endocrinologist or a reproductive gynecologist, quite when the IVF consideration comes up. But certainly if ovulation induction is not successful after a reasonable time frame, if there are other factors such as male factor endometriosis, which might make it desirable, you might get to IVF quicker if a patient is older. So there are a variety of reasons that IVF might be considered. And of course, again, patients' viewpoint on whether or not they want to go to IVF will always be considered. And this is just taking you through the stages of IVF, where there is the stimulation, and we just go through the various options. This is probably about 10 days of medication. We do of course need sperm, so we need to have the male partner in the same city, so that sperm can be provided. In the laboratory, we create with the eggs and the sperm, we create embryos, and then they're replaced in the uterus. And we hope, and probably in our hands, in an appropriate person, we've probably got a 40 to 60% chance that there will be a pregnancy related to a cycle of IVF. Now, this is a question that comes up quite a lot. If you know you've got PCOS, what do you need to do ahead of time? Now, again, I don't think this is black and white. I think the first thing to be aware of is if you know that your spontaneous menstrual cycle is really dodgy, that it's very unlikely you're going to have many periods on your own, you know that you're not ovulating, then ideally you're not going to leave it till you're close to 40 before you try and get pregnant. And just being aware that public funded treatment, the cutoff age is 40, so you need to be referred before the age of 40. So just to bring that into it. Whereas if you know that if you keep yourself fit and reasonably lean, your periods will come in a reasonable time frame, then you might, and you're relatively young when you're trying to get pregnant. And of course, there are all those other factors which come into it. Is there a partner? Is it the right time? I mean, it's something that as a doctor, it's extremely difficult to advise. I think it's really trying to put, if you like, the goals in order so to make some decisions around this. But just bearing these things in mind, how long you might wait before you talk with someone about it. So I think someone who knows they've got PCOS, who knows that they're not likely to ovulate on their own, who's perhaps further down that pathway towards the age of later 30s, 40, should probably fairly promptly be talking to someone about options if spontaneous conception doesn't happen. I think also family planning is really quite important. So this means, by this I mean, how many children do you want? And how important is it to have children? So if your goal is, it's really, really important to be a mother and you want to have 3, 4 children, again, that needs to be taken into account. How much reproductive time is there in case a spontaneous pregnancy doesn't happen, so that we have got time as the medical profession to give you a helping hand. Remember too that you might have very wonky periods and a spontaneous pregnancy could still occur. So if you're not wanting to be pregnant, don't forget about contraception. So I think, there's not a black and white, but if in doubt, do seek some medical advice. Now, I've just given you some of the criteria for public funding for assisted reproductive technology, or ART. And I think the key thing is, as I mentioned, the age. Don't get over 40 and then make a decision that you wanted funded treatment. If you're thinking you might, it would be a good thing to have that discussion and have the referral before the age of 40. You do need to be a New Zealand resident or a citizen, or be on an appropriate work visa. Need to be not a smoker. The weight is an issue in New Zealand. We don't have unlimited funds, and so there are criteria around lifestyle factors which might influence the chance of someone responding to one of these treatments. So for a female, the BMI 32 or less, and there's now a criteria for the male partner too. And it also depends on how many children are also in the relationship. There are some other things that, just as I've mentioned down the bottom, that might influence when you can be referred for publicly funded treatment. Now, I guess just to sum up, PCOS is a condition that affects far more than fertility, and I think it is a condition for life and therefore it needs to be managed appropriately for the life stage. Although we don't make a firm diagnosis of PCOS of someone in their teens, we certainly can have a strong idea that someone might have PCOS, and it gives the opportunity to really start educating someone about the importance of different lifestyle factors, which could in turn affect how the condition might manifest itself later on. Not everyone with PCOS will have problems with fertility, and I think that's a really important point, but there will be a small group of women who do have trouble and may need a helping hand. In the early stages, hair growth, acne, even female pattern hair loss might be an issue, and there's a whole range of strategies that a woman may want to manage it. But from the medical point of view, we always want to minimize cancer risk. We always want to minimize metabolic risks, so that someone in turn is leading a heart-friendly lifestyle. We want to minimize the risk of any longer-term complications. And as I've said to you, lifestyle changes are absolutely the cornerstone of improving symptoms, improving your future cardiovascular health, and often achieving fertility. But we've got other options for fertility treatment, which we've gone through. And if you're in doubt, have a talk with your primary care person, or if you've got an endocrinologist or a gynecologist or a fertility specialist, have a talk with them and make a plan, so that you've just, for the future, got, in a way, the strategies and the goals are set out. And thank you very much for your attention tonight.
So much, Stella. That was just just a whirlwind of information in the best possible way. Just incredible. We are just getting some thanks coming through from from our viewers, but we don't actually have any questions yet, and I'm just chalking that up to what a comprehensive presentation that you did, and you just covered so very much.
And it's getting late in the evening. I'm sure people are thinking about possibly a glass of wine.
There's often a few distractions in the background too with people. Certainly, if anybody's got any questions that they sort of mull on and think of later, feel free to email us at support@fertilitynz.org.nz, and we'll do our best to help you, or we'll reach out to Stella regarding that. Or of course, please do talk to your doctor or your fertility specialist with any questions that crop up as well. But here's a question that's just come up. I've just popped that through, Stella. Can you see
that? Yes, good question. Just thinking back to the Rotterdam Consensus, which is the universal criteria. So we've got the 3 criteria. You need 2 out of the 3. So one is the little follicles or cysts on the ovary. One is the male hormones either expressing themselves as acne or hair growth, or in the bloodstream as slightly higher levels of the male hormones, and one is the difficulties with ovulation. So yes, you could have difficulties with ovulation, you could have the male hormone excess and not necessarily see the changes on the ovary. And it is puzzling, and it has caused quite a lot of controversy around the world when they considered the Rotterdam Consensus, but that's how it stands at present.
So just that question was, can you have PCOS without cysts? Just for not everybody can see those. So thank you. That's a great question.
That was a good question, and it might seem very odd too. I guess one other thing that I would remind women is that, and I guess you might say we're medicalizing things, but we do think about, if you like, a warrant of fitness before pregnancy. So, not a bad idea, even if a pregnancy is not right now, but you're sort of thinking about it maybe in 12 months' time, go and see your primary care doctor and just make sure you're up to date with your vaccinations, you're up to date, about taking folic acid as a precaution 3 months before you get pregnant, and for the first 3 months into the pregnancy, that you've had a cervical smear done, that you've talked about your lifestyle, you've thought about your alcohol consumption, your smoking, all of those sort of things. So I sort of call it loosely a warrant of fitness, but I think that could be a very useful exercise and, will help some women just get where they want without in any way needing to come near someone like myself.
It's really great advice. Thanks, Stella. Yeah. Here we go, Stella.
So next question is, are there any alternatives to metformin? If I'm understanding that question, that means, is there a medication that's like metformin? We did experiment with some medications, and they are used in different parts of the world, that are called loosely, they've got a very long, complicated name, but loosely they're called the glitazones, things like pioglitazone. The problem with these medications is they actually cause weight gain. And as I've emphasized, the whole key in this is to try and make lifestyle changes that involve some modest weight loss. So the glitazones in New Zealand haven't taken off. We've preferred to use metformin. There are versions of metformin that we don't have available, but that are longer acting ones, which might in some countries be easier to take. With the way we prescribe metformin, it's actually usually given as 2 tablets a day of the 850 milligram tablets. Now, there are indications also that medications or supplements like inositol could be helpful. The problem is we don't necessarily have a preparation that's pharmaceutical grade, that we know exactly how much to take and when to take. But certainly if my patients ask me if they can take inositol, which is another agent that might increase insulin sensitivity, lower insulin levels, I'm certainly always in favor. And I have got patients who use this and have managed to get ovulation kick-started. Does that answer the question? I guess the important thing just to emphasize is that some modest weight loss and increasing exercise has probably an even better effect on reducing insulin than metformin. So you can get the same hormonal changes without unnecessarily even taking medication, prescription medication. So I'm hoping for that person that answered the question, and please come back with another question if I didn't. There's another question. They're coming in. It's great to have questions. What sort of research is happening regarding PCOS? Lots of research going on around the world. We've actually got some fantastic researchers in the University of Otago who are looking at a cell level and with various animal models. And are really doing some very exciting work, particularly around the causation of PCOS. And that work's also being done in the units where I have quite a close association, have trained in London, particularly at St Mary's with Professor Stephen Franks. There's a lot of research, a lot of clinical research also coming out of Imperial College, where I also trained with Professor Jerry Conway. So, and then in North America, some of the key researchers are people like Ricardo Aziz and Professor Rick LeGros. So if you're interested in this area, those are just some of the names who are doing some absolutely fabulous research. And of course, in New Zealand, the rest of us we're doing our best. Oh, yes. So the person who asked about metformin, and you've raised a really important point, and because I was trying to leave time for questions and not bore you all with too long a talk, I didn't go into too much detail. Metformin can certainly cause gut side effects, but for the majority of women, if you start it really, really slowly, so my patients know that we start with an 850 milligram tablet, and we start with just half a tablet, might even be a quarter of a tablet. So the full dose is 2 tablets a day, usually lunch and dinner so take it with food. But we might start with a quarter or even an eighth of that dose, and really slowly each week work up the dose and just settle at at increasing dose, see how someone's responding, either with if they're feeling a bit nauseous or getting any diarrhea. And usually with that very slow start, you can work up to the dose and get to the full dose without too much trouble. That's for the majority. It's not for everyone, but for the majority of women. So I guess for that person who's asking that question, if you were put on metformin, or you were just given a full dose straight away, it would be worth considering taking it again, doing it in the way that I've suggested, that very, very slow start, and always take it with food.
Thank you so much, Stella. That comes to the end of the questions that we've got there. Some really great questions in there. Thank you. And just an excellent presentation today, Stella. We really, really appreciate your time and your expertise and your support and contribution that you've made tonight for us. Really appreciate it.
It's a pleasure to join you. And can I just wish everyone absolute good fortune on this journey. It's not an easy journey, but I do wish you really well. And I hope it's just given you some ideas of resources and information. I think information is power. The more information that a woman with PCOS has, the more she can be on a level playing field and direct the questions that she gets the answers she needs. So very best with that. Good night, everyone.
Thank you. Good night, everybody. Have a good night.
Good night.